recording already?
Now it's recording.
Hi, everyone. My name is Jimmy Kauta. I'm an orthopedic surgeon living and working in Cape Town, South Africa. So my task here is to share with you our experience on the safety of hip and knee arthroplasty in a resource-constrained setting. So just a bit of background. First of all, before I get to the background, I have no disclosures related to this topic. This is Cape Town. We have just over 4 million people living in this city. About 29% of them are unemployed. The crime rate is very high, and we deal with a lot of trauma cases. So place for arthroplasty is really limited. So some authors have argued that Cape Town is made of two cities. On one side of the city, you are dealing with really affluent people, quite rich people living in this kind of accommodation. And on the other side, you have the impoverished side of the city, where most of the trauma burden and disease burden is mostly encountered. So the level of care in South Africa is broadly divided into 3 levels. You have the primary health care setting. This is where the patient would go for the first time. It includes community clinics and district hospitals. And then the secondary level receives referrals from the primary healthcare setting. The secondary hospitals include regional hospitals and large district hospitals. The difference being in regional hospital, you have 1 or 2 specialists per each discipline, and they have an ICU and they have an IK. In large district hospital, you have 1 or 2 consultants per specialties, but we have no high care or ICU facilities in these hospitals. So the narrative you're going to hear about during the course of the talk is based on my experience in a large district hospital. And then at the top, we have tertiary level hospitals. These are university teaching hospital. And each university teaching hospital receives referrals from secondary hospitals in their specific catchment area. So this is Mitchell's Plain Hospital. This is where I work every day. When I wake up, this is where I come for work. This hospital is situated in the Mitchell's Plain district, and this is a district with one of the highest statistics of crime and murder rate in South Africa. So we deal with really a lot of trauma here. This hospital is a 300-bed hospital, and out of those 300 beds, only 18 are dedicated orthopedic beds. This hospital employs only 1 orthopedic consultant, and that's me. With me, my team comprises of 4 medical officers. These are doctors who are working on orthopedics, hoping to get a training post one day to enter our residency program in the tertiary hospital at Cruz Care Hospital. And we have 4 interns. So on average, we do 75 surgical cases per month, 85% of them being mostly trauma cases, and only 15% being electives. And when I talk electives, I do total knees, total hip replacement, and also sport injuries related to knee and shoulder, mostly arthroscopic work. So when we talk about hip and knee arthroplasty at Mitchell's Plain, I receive some help from other surgeons. Talking about my training, I started this unit, working in this unit immediately after finishing my residency program at Cruz Care Hospital. And my first 60 or so joint replacement, I did them under direct supervision of a hip and knee fellowship trained surgeon. So this is what I call in-house training. I got trained for a year where each arthroplasty case I did was supervised by a fellowship trained surgeon. I do have a part-time knee surgeon working with me and another part-time hip and knee arthroplasty surgeon. These are private surgeons who donate their time most of the time for free. And on average, we do about 60 joints a year. So our operative setting, we have one orthopedic theater for about 700,000 people. So our catchment area serves 700,000 people. And all these people, they rely on one orthopedic theater, which is open Monday to Friday. And after hours as well as weekends, we share one emergency theater with general surgeons and gynecology. You can imagine orthopedics will always be pushed back for laparotomy due to gunshot abdomens and all of that. We have no high care beds in our hospital, and we share 18 beds. So which this means is my arthroplasty patient will be lying next to my infection patient and next to my femur fracture patient. So there is no isolation setting available. If we deal with resistant infection, then we would borrow a general surgery bed for those type of patients. Our patient profile, we're dealing with a lot of HIV infected patients. So our selection criteria for arthroplasty has to be quite tight. Also, our patients, some of them are morbidly obese, and most of them would present quite late with complex joint disease. The late presenters could be just because they've been waiting for too long, or they just been soldiering on with their hip and knee pain before they come to see the doctor. And it's usually poor people. The average household income, the monthly average household income in Mitchell's Plain is about 4,900 rand, equivalent to $180. So it is a very poor population. And this affects the follow-up with their care because with that, the transportation costs can be a problem. And often we rely on them following up after surgery with the peripheral, their hospitals or their clinics. So this is an example of the kind of pathology we see. They're not always this bad. On this patient, you can see this is advanced AVN, stage 4 Ficat and Allet classification with destroyed femoral heads, both sides, proximal migration on the left side. This is a young HIV patient. HIV is a big problem for arthroplasty in South Africa. Often they present with a vascular necrosis, often bilateral at different stages. This is multifactorial. We believe it could be virus related, but it could also be related to the drugs they take for HIV treatment. The protease inhibitors have been implicated in vascular necrosis. So this is what we get. And considering our setting, we are unable to do bilateral total hip because of the duration of the surgery. And possibly postoperative care may be limited in our setting. So we'd go ahead and do one side at a time. This patient has had the left hip replaced and waiting for a replacement of the right hip. Again, obesity is another problem that we face. This is a large morbidly obese patient requiring a total knee replacement. Our cutoff BMI for joint replacement is relative. We usually tend to be selective with patients with a BMI over 40, but essentially the limiting factor is our orthopedic bed. Our orthopedic bed will not accommodate patient weighing more than 150 kilograms. So once we get to that, we refer them to Cruise Care Hospital. Those are lighter than 150 kilogram will then receive the joint replacement. For arthroplasty of the knee, I use posterior stabilized knee cemented implant. We seldom use stemmed implant. It's a primary implant type that we use for our obese patient. So considering the fact that we are in a relatively unideal situation, using one theater for all comers, be it trauma, infection, arthroplasty. Our theater isn't laminar flow theater. Sometimes the aircon doesn't work. Our patient profile is riddled with HIV, diabetes, and obesity. So how does our complication profile compare to that of a tertiary hospital? Of course, the difference between the tertiary hospital is they have a dedicated arthroplasty unit. They have theaters which only do elective cases in a very controlled environment. So after looking at data over 4 years, we conducted a retrospective review comparing complication profile of hip and knee arthroplasty between our district hospital and our referral tertiary hospital, Cruise Care Hospital, here in abbreviation GSH. Over 4 years, that was between 2015 to 2018, we compared 228 cases at Mitchell's Plain versus 799 cases at Cruise Care Hospital. We look at the readmissions, reoperation rate, and all complication rate. After all that analysis, we actually realized that Cruise Care Hospital recorded more infections and more dislocations compared to our cohort. So then we asked the questions, what determines the safety of hip and knee arthroplasty in a low income setting district hospital like Mitchell's Plain? So we, of course, published our result and a discussion of this work in an international journal, which is available for your review. But the key element to safe arthroplasty in a low setting a hospital are multifactorial. The first factor we discussed is the surgeon's training. As I alluded to earlier, myself being the head of unit at this hospital, I underwent hip and knee arthroplasty training in-house for a year, where I had a visiting private fellowship-trained hip and knee surgeon coming to work with me on all arthroplasty cases I did for a year. That kind of solidified my registrar training or resident training in hip and knee arthroplasty, and I carried on. And alongside me, I still worked with other arthroplasty surgeons. So surgeons training is very important in assuring the safety of hip and knee arthroplasty in low and middle income settings. And of course, the next point we discussed was selection criteria. Our population, as we know, HIV is endemic, diabetes is endemic, so is obesity. So what do we do for HIV? We make sure that our patients that come in for hip and knee arthroplasty have a lower than detectable levels of the viral count. If we can't find the viral count, if it's less than detectable level, then we feel those patients are safe to receive the joint replacement. And the other factor we look at is the CD4 count. Not so rigorously. We want a CD4 count more than 350 per liter. And of course, we look at the albumin as well. The albumin must be more than 30 grams per liter. So that's what we look at for HIV. Diabetes gets screened. All patients with high BMI get screened for diabetes as well. Even if there are unknown diabetes, we do the HbA1c test. We want that to be less than 8 for elective arthroplasty. And of course, patients who are obese, our BMI cutoff is generally 40, but we go by how much weight our bed can support. And often patients heavier than 150 kilograms will not be accommodated on our operating table. We look at the anesthetic classification of our patient, and everybody who is ASA 3 gets referred to a higher level of care. So in essence, Surgeons training and strict selection criteria are important in ensuring safety of hip and knee arthroplasty. And of course, we follow standard operating protocols, adequate scrubbing, surgical prep, and we use perioperative antibiotics, 1 shot at induction and 3 more shots after the surgery. It is a controversial topic at this moment, but considering our environment, we still give 3 more antibiotic shots after the surgery. So looking into the future, how can we help or maintain the safety of hip and knee arthroplasty in low and middle income settings? I think we need to specifically address surgeons training and also ensure availability of resources such as implant that need to be used. What can be controlled is surgeons training. Currently, surgeons from low and middle income countries in Africa often leave their home countries to go train for the basic orthopedic training in other affluent countries. They go to Europe, they go to America, they come in South Africa to train as resident to become orthopedic specialists. After they finish that, they are required to return home and start practicing, basically without further subspecialty arthroplasty training. So for those who can afford it, they may go in other countries and do a fellowship. But usually these fellowships are 12 months, sometimes 24 months. And once they're done, they're back home on their own, carrying on as arthroplasty surgeons. This could be limiting because the exposure during a fellowship program can be limited as well. How do you deal with revision cases, complex cases? So I would favor a mentoring system rather than a fellowship program. And when I talk about a mentoring system, I'm seeing the fellowship directors creating a mentoring program where they make an effort to visit their ex-fellows or their previous fellows into their own hospital setting to see how they're dealing with complex cases, to offer help in terms of physical presence and mentoring in theater, but also in ways of looking at how they can navigate the specific challenges around operating in a low-income setting. So this would be a long way to ensuring that hip and knee arthroplasty is safe in low and middle income countries. That was my take. Thank you very much for listening.